So let's talk through the first example. The first example is a 65-year-old gentleman who's a lifelong smoker. They're known COPD and they've come in with a 3-day history of worsening shortness of breath and a productive cough. My senior tells me to do an ABG on this patient, and these are the results. The pH is normal, but it's on the lower end of normal, so the acidotic side. So that's a clue. The PCO2 is high, the bicarb is high, and the PO2 is low. Let's use the 5-step framework. First thing we're going to look at is the pH. So the pH is normal / low. So is this something would we expect the pH to be normal if the patient is looking really unwell? They're short of breath, they've got a productive cough, they've got a background of COPD. No, we wouldn't expect the pH to be normal. So that is telling me that some sort of compensation has happened in this patient. But we'll find out what the primary problem is. The next thing is PCO2. Before I talk about PCO2, there's one thing you need to remember. You need to find out what the primary problem is. It's either going to be respiratory or metabolic. In this patient, the patient has COPD. So that's a hint that it must be something to do with the respiratory system. So we look at the PCO2. The PCO2 is high. Is that expected in a COPD patient? Absolutely. The reason is because when a patient has COPD and they've come in with shortness of breath, they're not able to get the CO2 out of their lungs. So what happens? Their lungs are full of CO2, which causes the PCO2 to be high. If the PCO2 is high, would that cause acidosis or alkalosis? A high PCO2 would cause acidosis because the PCO2, or the CO2 actually, becomes carbonic acid, and the carbonic acid causes acidosis. Is it respiratory or metabolic? As I said before, PCO2 has to do with the lungs, so it is respiratory. However, as the pH is normal, it doesn't really show that the patient is in respiratory acidosis. So once again, this is showing me that some level of compensation has taken place. The third thing we look at is the bicarb. The bicarb is high. So the patient has respiratory acidosis, but their bicarb is high. A high bicarb should normally cause alkalosis. So this is the kidney's way of trying to compensate and normalize the pH. Number 4, compensation. Yes or no? Yes. And if yes, is it partial or fully? It's fully. And the reason is because not only has the body tried to normalize the pH from the acidotic environment, it has also managed to make the pH normal, which shows you that it is fully compensated. If the body has tried to compensate for the acidosis and the pH has still remained acidotic, then it would have been partial. The fifth thing is PO2. PO2 is 7.8, so that's low, and that is hypoxic. Is that expected? Once again, yes. And the reason is because COPD patient who's struggling to breathe, which means that they're not getting enough oxygen into their lungs, and the CO2 that's in their lungs is staying there. So the oxygen that they're struggling to get in causes hypoxia. The CO2 that is unable to come out of their lungs causes a high PCO2. And because COPD is a chronic condition, the body has had time to try and compensate and normalize the pH by using the kidneys to retain bicarbonate, which has resulted in high bicarb and in turn a normal pH. This is the classic ABG example for an exacerbation of COPD patient. Because they're short of breath, they're not getting enough oxygen into their lungs. So their PO2 is low. They'll be hypoxic. At the same time, they're not able to breathe out the CO2. So the CO2 stays in their lungs, which causes a high PCO2, and that causes respiratory acidosis. Because COPD is a chronic condition, the body has time to compensate, so the body tells the kidneys to retain bicarbonate to help normalize the pH. I want to use a little diagram to illustrate exactly what I mean. I used it in the last video as well. So this is the acidotic side and that's the alkali side. The patient has a high PCO2, so with respiratory acidosis, you would expect it to be on the acidotic side. This is normal. That is the normal pH. Sorry for the wonky line, but that is meant to be 7.4. So with respiratory acidosis, the pH was initially there. Now, if the line is here and you want it to go to normal, you have to create an alkalotic environment to push the pH in this direction. And that is why the kidneys start holding on to more bicarbonate to try and push the pH from an acidotic number to a normal level, which is what's happened here. Let's talk through the second example. The second example is a 24-year-old patient who is a known type 1 diabetic. They've come in with nausea, vomiting, abdominal pain, and an examination, they look dehydrated with Kussmaul breathing. You do an ABG on this patient, and these are the results. pH is 7.24, so that is low. PCO2 is 3.2, so that is also low. Bicarb is 12, once again low, and PO2 is 12, so that is normal. Let's use the 5-step framework. So the first thing we're going to look at is pH. pH is 7.24. That is an awful H, but pH is 7.24, so that is low. And if it's low, that means the patient is in acidosis. So if it's in acidosis, we need to try and find out if it's a respiratory cause or a metabolic cause. This is what's going through my head. If it's respiratory, what would you expect the PCO2 to be? You would expect it to be high. If it's metabolic, what would you expect the bicarb to be? You would expect it to be low. So let's find out whether it's a respiratory or metabolic cause behind the acidosis. 2. PCO2. As we said before, it's low. So would you expect it to be respiratory acidosis here? No. The reason is because if it was respiratory acidosis, you would expect the PCO2 to be low. Sorry, you would expect the PCO2 to be high, but it's not. So you know that it's not a respiratory cause, it must be a metabolic cause for the acidosis. Number 3, bicarb. what would you expect the bicarb to be if it was metabolic acidosis? The bicarb would be expected to be low. Is it low in this patient? Yes. So we've just confirmed that it's metabolic acidosis. Now, metabolic acidosis is not enough as a diagnosis. We need to see if there's any compensation. So, is there compensation? Let's find out. So, I use this diagram again. Acidosis, alkalosis. That is the normal pH. So in this patient, their pH is 7.24, so that is there. What does the body have to do to try and bring the pH from there to there? It has to create an alkalotic environment to shift the pH in that direction. So the primary problem is metabolic, so the way that the body can compensate is through the other system, which is the respiratory system. So if you want to create an alkalotic environment in the respiratory system, you need to reduce the CO2 levels. And that is what's happened. That is why the PCO2 is low, because it is trying to create an alkalotic environment to shift the pH from acidosis to normal. So is there compensation? Yes. There is respiratory compensation. Is it fully or partial? In this case, it is partial. How do we know? Because the pH is still abnormal. If the pH was normal, then you could say that it was fully compensated. But as the body has tried to compensate, but it hasn't managed to get the pH to normal, you say it is partial. So the diagnosis for this patient is partially compensated metabolic acidosis. And number 5, just for completion, PO2 is normal, so there's no signs of hypoxia. This is your typical ABG for a DKA patient, and I'll tell you why. DKA itself has the word acidosis in it, so you know that the patient is going to be in acidosis. It's ketoacidosis, so it's a metabolic cause. Now, the patient has a low CO2, and this is the body's way of trying to compensate for the acidosis. This is evident in their breathing. Kussmaul breathing is the body's way of trying to get rid of as much CO2 in their lungs in order to create an alkalotic environment to move the pH from here, which is in the acidotic area, towards normal. Let's look at the third example. The third example is a 19-year-old who's been brought into ED after they fainted in the exam hall. They're alert, but they seem very anxious and they're breathing very rapidly. You do an ABG on the patient, and these are the results. So once again, we're going to use the 5-step framework to come up with a diagnosis. Number 1, pH. pH is clearly high. So as the pH is high, they're in alkalosis. And we want to find out whether it's a respiratory cause or a metabolic cause. If it was a respiratory cause, we would expect the PCO2 to be low, and if it was a metabolic cause, we would expect the bicarb to be high. So let's see which one is the primary problem. Number 2, PCO2. PCO2 is 3, so that is low, and that shows us that is respiratory. So the primary cause of the alkalosis is respiratory, so it is respiratory alkalosis. Number 3 is the bicarb. The bicarb is normal, which means that the body hasn't had time to try and compensate, to try and bring the pH from alkalosis to normal. So let's use this diagram again. Acidosis, alkalosis. This is normal. Still not managing to do a straight line, but this is alkalosis. This is where the patient is at. If you wanted them to try and compensate, you would try to make the body create an environment which is more acidotic. So as the primary problem is with the respiratory system, you have to use the metabolic system to try and compensate. So if you want to use the metabolic system to try and create an acidic environment, you would have to try and reduce the number or the amount of bicarbonate. In this example, the bicarbonate is normal, so that shows you that there hasn't been any compensation in the body. So number 4, compensation. No compensation. If there was compensation and the body was trying to shift the pH from alkalosis to normal, you'd expect the bicarb to be low, but it's not. So the diagnosis is uncompensated respiratory alkalosis. And for completion's sake, we'll look at number 5, which is PO2. And that is, it's a bit high, but it's normal. The reason it's 13 is because they are over breathing, because they're anxious. So those are the 3 examples I wanted to talk you through. These are must-know conditions that you're bound to come across when you're working as a junior doctor in the hospital. Hopefully you understand how to use the 5-step framework to interpret an ABG. So now, when a senior asks you to interpret one, you can stay calm and confident.